Many well-known persons have had heart attacks or are at great risk for heart attack. Acute coronary syndrome, otherwise known as coronary heart disease, encompasses coronary artery disease and heart attack. It involves anything affecting the coronary arteries that could lead to a heart attack. Coronary heart disease is the single largest killer of Americans, but the incidence is now on the decline due to an overall decrease in modifiable risk factors, such as smoking. Treatment is generally occurring earlier these days due to a higher awareness of the problem and earlier treatment. For example, people are monitoring their cholesterol levels, and treatment of hyperlipidemia is more common. However, risk factors such as obesity, diabetes, and hypertension are still quite prevalent. Acute coronary syndrome, specifically, is defined as a buildup of plaque in the arteries with periods of ischemia that could lead to injury or myocardial cell death. The normal anatomy and physiology of the heart. Blood flow is from the right atrium through the tricuspid valve to the right ventricle, into the pulmonary arteries, to the lungs where oxygen is picked up and carbon dioxide released. Oxygenated blood then travels through the pulmonary veins to the left atrium, to the mitral valve, left ventricle, to the coronary arteries, and to the system via the aorta. Deoxygenated blood returns through the superior and inferior vena cava back to the right atrium. Remember then that the pulmonary artery will have the least amount of oxygen and the pulmonary veins will have the most. Slide 3. Coronary arteries. Normal anatomy and physiology. The coronary arteries branch from the aorta and extend through the myocardium. The heart must feed itself with oxygen before feeding the rest of the body. There are two major arteries, the right and left coronary arteries, which branch off the aorta above the aortic valve. From the left coronary artery, there is the left anterior descending, or LAD, and the left circumflex, the LCX. The LAD runs straight down the front of the left ventricle. The left circumflex runs around the left ventricle, getting to the posterior or backside of the heart. It's the left ventricle that requires the most blood flow. The right coronary artery, the RCA, feeds the right side of the heart, and branches come off from the RCA that feed the inferior aspect of the heart. All arteries lie in grooves, making it easier when bypasses are necessary. Blood flow through the myocardium occurs when the heart is relaxed, diastole. Slide 4. The worst artery to have blocked is the LAD, since it feeds most of the left ventricle. Anterior wall infarctions carry the highest mortality rate of 25%. Patients that have anterior wall infarcts are more likely to have the greatest complications in dysrhythmias or heart failure. Lateral or posterior wall infarcts occur from the occlusion of the circumflex artery. Patients who have obstruction of the RCA are more likely to have inferior wall infarcts. With the inferior wall infarction, a lack of blood flow to the bottom of the heart leading to dead tissue, there is a 10% likelihood of death. So we are more dependent on having the left side of the heart working than the right side, and we can actually get by with very little atrial pumping. So, ejection fraction. That is the percentage that is ejected with each beat. It's a measurement of contractility. It's the same as stroke volume, except that it's stated as a percentage. Cardiac output. Stroke volume times the heart rate. Stroke volume is equal to the amount ejected per heartbeat. Preload is the stretch at the end of diastole and is determined by venous return. Afterload is the resistance to pumping by the left ventricle. Slide 6. Risk factors. We cannot change our age, ethnicity, gender, or heritage. These are non-modifiable risk factors. Modifiable risk factors are those which we can change. We can stop smoking. We can lose weight. We can decrease stress or decrease our blood pressure through better management of our stress and diet and exercise. We can lower our lousy cholesterol, the LDL, increase our activity, decrease salt and alcohol in the diet, and control our blood sugar. The best way to prevent heart disease is to work with the modifiable factors. Smoking inflames the endothelial lining and constricts arteries. High blood sugars lead to a propensity for clotting and lead to a sluggish blood flow and harms the endothelial lining as well. Cholesterol monitoring. Ideally, LDL levels should be under 130 milligrams per deciliter, and the triglyceride levels should be below 150 milligrams per deciliter. High levels of low-density lipoproteins contribute to coronary heart disease. Cholesterol control. Hyperlipidemia, the prevention and treatment. Cholesterol can be controlled through diet, but in many cases it is essential to decrease the cholesterol and diet control if diet control isn't working. Statins, fibrates, and resins lower cholesterol levels by signaling the liver to decrease its production. Cholesterol-lowering drugs will lower the LDL and increase the HDL. HDL provides protection against harm to endothelial linings in the coronary arteries, and studies have shown that the risk for heart disease is quadrupled once cholesterol levels go below 300 milligrams per deciliter. Examples: statins, which are the first-line treatment, such as atorvastatin or Lipitor, lovastatin, Mevacor, and simvastatin, Zocor, work by decreasing the rate of production in the liver. Fibrates, gambirazole, or Lopid, work by increasing cholesterol secretion into the bile. And resins or bile acid sequestrants like cholestyramine bind bile and excrete extra cholesterol in the stool. So slide 9, angina. Angina is caused by insufficient oxygen to meet the needs of the myocardium. A patient with angina will have chest pain and tightness. This is also known as cardiac ischemia, which could progress to injury and infarction, which is cell death. Angina should be treated immediately by increasing the available oxygen and decreasing demand. We decrease demand by having the patient rest. Ceasing activity decreases workload of the heart. We increase the oxygen supply by giving the patient oxygen and increasing blood flow to the myocardium. When a patient has cardiac ischemia, there are ST segment changes, which indicate problems with the ventricle recovery. If ischemia goes too far, there will be injury to the tissue, and if the injury is left untreated, there will be infarction or cell death. It is critical to stop the injury. Slide 10. Reading for this case, which kind of angina do you see? A 42-year-old male visits the ER. He says he has developed severe chest pain radiating to the jaw while he was mowing his lawn. You give him sublingual nitro and oxygen. I previously mentioned both increasing blood flow and oxygen. The nitroglycerin increases blood flow by relaxing or dilating the coronary arteries, as well as relaxing the ventricular walls. Within 5 minutes, he has no pain. This is an example of a patient with stable angina. The patient has stable plaque with no clots forming, and once the oxygen supply has been increased through the use of the nitroglycerin, the chest pain goes away. He has stable angina since the pain went away with treatment. If it were unstable, he would continue to have pain despite treatment. Patients with unstable angina have a frightening condition. They can have a heart attack at any minute. They will end up in the hospital to receive a workup to determine the extent of the occlusion. They might be managed with medications such as ACE inhibitors, beta blockers, aspirin, and cholesterol-lowering drugs for a while, but eventually they require some kind of an intervention, such as a coronary bypass graft or CABG, or percutaneous coronary intervention, PCI. Slide 12. The typical symptoms of angina is chest pain. After all, the heart muscle is being deprived of oxygen and is screaming out for more. It's like a muscle cramp. Usually the pain is squarely in the chest and feels like pressure, tightness, and squeezing. Typically the pain will radiate down the left side, since that's where most of the heart muscle is located. Some people have strange kinds of pains that are lower down, such as epigastric, or in the throat or left shoulder. It can be difficult at times to determine if the pain is cardiac, orthopedic, or digestive. Slide 13. When a patient is having chest pain, the priority is to decrease the oxygen demand and increase the oxygen supply. Calm the patient. Morphine is used to help with anxiety in that it not only directly relieves pain, but it also increases blood flow to the coronary arteries. Put on enough oxygen to achieve at least a 95% saturation. Give nitroglycerin, 3 tabs under the tongue, 1 every 5 minutes, or you can spray nitroglycerin under the tongue. Review these factors that contribute to the decrease of supply and increase in demand. How does a heart attack happen? First, atheromas form. An atheroma is a clump of fat inside the artery that is covered with a smooth layer. An atheroma occurs from the endothelial inflammation and high LDL levels. We all have some degree of plaque buildup in our arteries, which is okay as long as the plaque is smooth. If the atheroma becomes inflamed or aggravated, the smooth layer cover will break apart and the plaque junk becomes jagged. When that jagged plaque is there, microclots which form and dissolve can be caught. The danger is that the clots can catch more clots and grow. When there are clots forming and obstructing blood flow, we call it acute coronary syndrome. There is inflammation going on all the way through this process. Initially, inflammation will cause vasoconstriction, which further compounds the problem. Early plaque formation might partially occlude the coronary artery, but the artery will compensate by dilating. The arteries can dilate as much as 6 times normal when there is exertion. This is what happens with stable angina. In stable angina, the patient who is exerting will have chest pain during that exertion. The pain will subside with rest, nitroglycerin, or oxygen. But if the plaque ruptures and clots form, the patient might have chest pain for no reason. The chest pain might even occur in the middle of the night, waking the patient. If there is enough of a clot buildup and the oxygen-carrying blood cannot get to the myocardial tissue, the tissue dies, an infarction. And that is what we call a heart attack. Death of myocardial tissue might be called Q-wave infarction, meaning that when looking at the EKG tracing, you will see a wave right before the QRS. This wave indicates poor ventricular function and is likely for heart failure. Let's talk about angina versus myocardial infarction, or an MI. How would a patient look who is having an MI as opposed to a patient who is having angina or a period of ischemia? The patient with ischemia, or temporary oxygen deprivation, will get relief from resting, oxygen, morphine, or nitroglycerin. The patient who is having an infarction, or cell death, will have continuous pain as cells are dying. Morphine will lessen the pain but won't get rid of it altogether. If the patient is indeed having a heart attack. Changes will occur in the ST segment when the myocardial cells are deprived of oxygen. The ST segment represents ventricular repolarization, or the time when the ventricles are recovering and getting ready to contract again. There are 3 possible changes. With ischemia, there is a 2-wave inversion. With injury, there is ST segment elevation. With infarct, there's a Q wave. Slide 17. Changes in the cardiac enzymes. When myocardial cells are damaged, they immediately release enzymes into the bloodstream. Troponin levels are the most frequently tested because they stay elevated for the longest. Serial tests are done to see if the enzymes are rising. When they're rising, we can assume that the myocardial cell death is occurring and the intervention is needed right away. Slide 18. The woman patient with diabetes is least likely to have symptoms. Women, elderly, and diabetics often don't have the usual signs and symptoms of ischemia. Diabetics in particular may have neuropathies and don't have sensations that normal people do. Slide 19. The former gold standard for treatment, and I say former, for heart attack was morphine, oxygen, nitroglycerin, and aspirin, known as MONA. Note that while MONA is a great acronym, the letters do not actually indicate the order of administration, which should be oxygen, nitroglycerin, aspirin, and finally morphine. Morphine should only be administered after the nitroglycerin and aspirin due to the increased risk of death or subsequent heart attack associated with morphine administration, especially with a non-ST elevated MI patient. Oxygen is now only indicated if the O2 sats are below 94%. Further, the aspirin should be chewed by the patient to speed absorption for its anticoagulant side effects. It is not given for pain. We might also add an ACE inhibitor like lisinopril, Zestril, to get rid of the fluid and dilate vessels, therefore decreasing preload and afterload, and therefore the workload of the heart. We might even add a beta blocker like metoprolol, low pressor, to immediately decrease the heart's oxygen demand by reducing the heart rate. Morphine is a great drug for decreasing workload of the heart. Preload is decreased through venous dilation. The heart is more relaxed and the patient is more calm. Nitrates. Dilate the vessels, immediately increasing blood flow and oxygenation of the heart muscle. Examples are isosorbide or Isordil and, of course, nitroglycerin. Anticoagulants. The patient with chest pain might be forming a clot or clots in the coronary arteries, so it's important to stop the clot from getting bigger. Aspirin, ASA, clopidogrel or Plavix, heparin, and integralin are known to inhibit platelet stickiness and stop the clots from getting bigger. Beta blockers slow down the heart rate and heart contractility. Examples are metoprolol, propranolol, atenolol. Hold beta blockers for heart rates below 60 and for people with asthma. Think of beta blockers as being the opposite of epinephrine. Beta blockers are like the brakes on a car and will slow the heart rate, but can also cause bronchoconstriction. So how can a beta blocker help your patient who's in the midst of a heart attack? A beta blocker will increase the diastole time, which allows better blood flow through the coronary arteries, exactly what is needed. Patients who are having a heart attack are not getting adequate blood flow to the myocardium. Beta blockers decrease heart rate and contractility. ACE inhibitors block the angiotensin-converting enzyme. Angiotensin is an enzyme that leads to renin and aldosterone hormone outpouring. Renin causes vasoconstriction, and aldosterone causes sodium retention. So ACE inhibitors cause the opposite of what renin and aldosterone do, leading to a decrease in blood pressure and workload for the heart. 26. The number one most frequent severe complication of an MI is the fatal dysrhythmia of VFib, ventricular fibrillation. The death of cardiac muscle cells hurts the cardiac conduction system. The ventricles will fail to repolarize and will not get a chance to reorganize before a stimulus comes from above. With VFib, there is rapid firing and a quivering of the heart that cannot effectively pump blood anywhere. VFib is so common with cardiac cell death that now defibrillators are kept everywhere. When a patient has VFib, the first and most important thing to do is to defibrillate. Without defibrillation, everything else you do is useless. The second complication is heart failure. Post-MI patients will often end up with a failing heart pump due to death of cells that would ordinarily contract. Many post-MI patients end up with really low ejection fractions and poor cardiac output. Cardiogenic shock might occur if the pump completely fails and there is no cardiac output. Patients in cardiogenic shock require all kinds of stimulant drugs such as epinephrine to get the heart moving. A temporary pump might even be inserted, an intra-aortic balloon pump, to get the heart going again. The patient might even need a transplant. The patient needs to be monitored and watched for VFib. Lidocaine or amiodarone might be infused to decrease the ventricular irritability. The number one complication to look out for is dysrhythmia. It's important to treat the patients immediately who have It's important to treat patients immediately It's important to treat the patient immediately who is suffering from myocardial cell injury. There are 3 ways to restore perfusion to the heart muscle. Thrombolytics can be administered through the IV to break up clots. Percutaneous coronary intervention, PCI, can be done to compress plaque against the coronary walls and place stents or remove plaque in a roto-rooter style. Coronary artery bypass, or CABG, can be done to bypass the occluded coronary artery. Thrombolytics work by breaking up clots. They are different from anticoagulants since the anticoagulants only stop clots from forming. Thrombolytics are dangerous because the patient can bleed to death easily when the clots are broken up and not allowed to form plugs or over injuries. To be a candidate for a thrombolytic, you must have started having chest pain within 3 hours, and you must not have had recent surgery or injury. From the list below, the patient with chest pain, unrelieved by nitro, and the patient with ST segment elevation and the 69-year-old are the only ones who should receive clot busters. The other patients are at too high a risk to be clotless. It's too late for thrombolytics for the patient who began having chest pain 2 days ago. Patients who can't receive thrombolytics could have a percutaneous coronary intervention, a PCI, in the cardiac cath lab. A PCI can be done by inflating a balloon in the coronary artery. A stent might be added, or plaque might be removed in a roto-rooter style fashion. A catheter is threaded through the large femoral artery and guided into the coronary arteries. The plaque is then compressed against the wall of the artery. Oftentimes, a stent will be inserted to help keep the arteries open. Afterward, the patient should be on bed rest for a minimum of 6 hours with the legs being held straight. It is essential to check the groin for bleeding and the pedal pulse to make sure there is no loss of circulation from arterial damage. Angioseal, perclose, is sometimes used to keep the puncture site from bleeding. Some kind of anticoagulant is needed after a procedure. If stents are placed, anticoagulation might be needed for up to a year. In coronary artery bypass grafting, a vein from the leg, the saphenous vein typically, or an artery from the chest, the mammary, is taken and put into the coronary circulation. The vein is attached to the artery and then goes to the occluded side of the area that is not receiving enough perfusion. Stress testing. A stress test is done periodically after a patient has had a heart attack to test the ability to handle exercise. A stress test might also be done for patients who have had coronary heart disease to evaluate whether further intervention is needed right away. To diagnose acute coronary syndrome, a stress test might be done. In a stress test, the patient is asked to do exercise such as riding a stationary bike or walking on a treadmill. Blood pressure monitoring and EKG tracing are done at the same time that the patient is exercising. The patient should be able to do the exercise without chest pain or dysrhythmia. The stress test is a good way to determine that drugs are working. For example, the patient who is now taking beta blockers or ACE inhibitors might now be able to walk on a treadmill without chest pain. If there are ST changes during the stress test, it means that the demand is exceeding the supply. The stress test can also be done with drugs that simulate exercise. Some patients with abnormal resting ECGs or those who are unable to walk can safely be exercised pharmacologically instead of by walking on a treadmill. The patient will typically receive a pharmaceutical such as dipyridamole or adenosine, both of which are vasodilators, or dobutamine, which stimulates heart rate and pumping force, while a cardiologist or a physician assistant is reviewing the ECG tracing and checks blood pressure periodically. A thallium scan is used to evaluate the blood supply to the heart muscle. It can identify areas of the heart that may have poor blood supply as a result of damage from a previous heart attack or blocked coronary arteries. While exercise testing has long been a standard examination in the diagnosis of coronary artery disease, in some cases the thallium scan may be more sensitive and more specific in the information it provides. In other words, the test may be better able to detect a problem and to differentiate one condition from another. A thallium heart scan may be more accurately detect ischemic heart disease. This type of scan is most likely to be helpful in cases in which the exercise test is inconclusive. The patient cannot exercise adequately, or quantitative evaluation of blood flow is required. In addition to evaluating coronary artery disease, thallium scanning can help to evaluate blood flow following treatment of clogged arteries with a coronary artery bypass graft or with angioplasty. The thallium scan is performed in conjunction with exercise stress test. At the end of the stress test, once the patient has reached the highest level of exercise that he or she can tolerate, a small amount of a harmless radioisotope, thallium-201, is injected into the patient's bloodstream through an intravenous IV line. The patient then lies down under a special camera called a gamma scintillation camera, which makes photographs of the gamma rays emitting from the thallium. Cold spots that appear at rest as well as during exercise often indicate areas where the heart tissue has been damaged, for example, as a result of a prior heart attack. Sometimes perfusion is adequate during rest, but cold spots appear during exercise. When the heart has to work harder and has a great demand for blood, this can indicate some blockage in the coronary arteries of producing a condition called ischemia. Cardiac rehab. Cardiac rehab occurs in 4 stages. Immediately after the event, the patient might be recovering from a heart attack or have had a CABG or a PTCA. The patient gradually begins to ambulate down the hall and get rid of catheters and lines. 2, during the 6 weeks following the event, the patient is home with visiting nurses, and gradually activity is increased to walking upstairs and around the block. 3, patient can begin exercise program under supervision, and the patient has vitals checked before and after exercise. Emergency equipment is available during the exercise. 4, the patient is now exercising independently and has frequent checks by the cardiologist for stress tests. The patient may also be monitored on occasion in a structured exercise environment. It is safe to resume sex under the following conditions. You should be able to walk up 2 flights of stairs without problems, such as vital signs changes or chest pain. You should not have sex after drinking alcohol or eating a lot. You should be comfortable and non-stressed, and it's not a good time to have an affair. The temperature should not be too hot, and you should be in a comfortable position.